when we are discussing the chief complaints, it is always prudent to talk in the patient's own language. Okay, so 40-year-old male patient does away with your age, the gender of the patient. A rickshaw puller by profession with poor socioeconomic status. What does poor socioeconomic status state? It is measured by Swami scale. There is a modified Swami scale. Okay. Then progressive ulcer, difficulty in articulation, and excessive salivation. We've spoken about this. So carcinoma tongue can present to you in various ways. You can have, number one, a lump. You can have an ulcer like this patient. You can have a papillomatous lesion, and of course you can have a very rare variety. I'm writing this in blue, which means you can have a malignancy in a fissure. Okay, which means that suppose this is your tongue, you have developed a crack in the tongue, a fissure which goes deep, and you have malignant tissue proliferating around this. Okay, these are how carcinoma tongue can present to you in any patient. Okay, now let's go into the history. Any tongue lesion can start off as a nodule like this, and when this blood supply is hampered as the tumor is rapidly progressing, you've heard of something called a Gompertzian growth of any tumors. Okay, so the tumor will have its clinical presentation after most of the cells have divided and you have a very large swelling. Now what happens when the swelling is very large? The blood supply that is coming in is unable to sustain it, so the top of it starts to ulcerate. Now when this ulcerates, you land up with an ulcer. By this time the tumor has also developed collateral supply from other vessels in the vicinity, and then it starts to proliferate rapidly. So this is what had happened with our patient. Now why is the patient having pain? The pain can happen due to the fact that carcinoma tongue is one entity where the nerves are involved, the lingual nerves can get involved. Okay, now this dull aching localized pain can go to your ipsilateral ear, it can go to your ipsilateral ear. Okay, and why is this? This can go by auriculotemporal nerve. It can go by the auriculotemporal nerve. And of course, there's a difficulty in articulation of speech. It is quite evident because of the patient's clinical domain. And of course, there will be a bit of drooling of saliva, and this area is very sensitive. It's very painful. There are free nerve endings there. So the patient is unable to tolerate extremes of temperatures of food or maybe a lot of spicy food. Okay. Now, why is the history of dental surgery very important? Because sometimes the patient might have dentures. Dentures are false teeth. Now, if you have a sharp or an ill-fitting denture, that might chronically irritate your tongue, and then the patient might land up with an ulcer of this sort, which might be malignant in the long run. Now, why do we have weakness and loss of weight? What is significant weight loss might be asked as a separate question. Again, weakness happens due to two reasons. Okay, because the person cannot eat, number one, and number two, you have something called a cancer cachexia syndrome, in which the tumor secretes something called a tumor necrosis factor alpha, which might cause cancer cachexia. You might be asked by some examiner, if the examiner has an interest in surgical oncology, what is a drug of choice given in cancer cachexia? It is magistrol acetate. Okay. Now, why is the history of medical comorbidities very important? Because see, these patients are chronically old. They might have something like a coronary artery disease. They might have something called hypertension. They might have something called diabetes mellitus. Okay, now these factors can actually lead rise to difficulty in reconstruction. Why? Sometimes you might use a flap for reconstruction if the patient has something called a microangiopathy. It is very difficult for them to have a surviving flap. We've seen various patients lose their flap because of these little tiny comorbidities. Of course, the patient might be on drugs which are antiplatelets, which can cause bleeding. Dual antiplatelets must be stopped, and various protocols must be followed previous to surgery. Now, you can have things like bronchial asthma, COPD, tuberculosis. Now, bronchial asthma, COPD, if the patient requires a tracheostomy, because you might require to resect the floor of the mouth. If the patient might require a tracheostomy, then it's very important to get a pulmonary screening done before. Tuberculosis, why? Again, because certain ulcers fall under differential diagnosis, and these ulcers can mimic carcinoma tongue. Okay, so these are very important. And the diet, of course, is important, because if you're coming from a poor socioeconomic status, it's quite evident that a diet quality will not be good, which can cause chronic inflammation later on and cause cancer. These are less established facts, of course. And coming to the most important thing in carcinoma tongue, that is, or rather in any head and neck cancer, is the use of tobacco and the use of alcohol. Okay, now tobacco and alcohol are synergistic. They are synergistic, which means that both of them are acting in conjunction. Okay, the thing is, this is dose dependent. Dose dependent means the more you have, the more you get. So if you are a light tobacco user, that is like less than 10 cigarettes per day, or you are a heavy cigarette user, that is more than 30 cigarettes per day, the risk in a light smoker is 1.5 times, and the risk in a heavy smoker is 4 times. The risk increases when you do more than 20 cigarettes per day. What is a pack? A pack is not 10 cigarettes. When you're buying one pack of cigarettes, it's 10 cigarettes, yes. But when you're buying a pack in surgery or in any medical examination, it is 20 cigarettes. Probably the guidelines have been lenient by saying you can buy a big pack of cigarettes to consider that as a risk factor. Anyways, now that is one thing. Okay, and of course there are a couple of syndromes which you can read in the text of the book, which can lead to oral cavity malignancies. Of course, the most important one is Fanconi's. Okay, now this does with your history. Now coming to general examination, if it is normal, you can just say in the examination, general examination is essentially normal. Don't waste time in a short case. So I'll just tell you a very tiny thing which is important. Why is anthropometry important? Because from the height and weight you get BMI. No, you get something which is important in cancer, that is, you get something called a BSA, that is body surface area. Okay, body surface area, which means you can give preoperative chemotherapy. What formula is used for this? You use something called a Du Bois formula. In Du Bois formula, we actually calculate the body surface area, and we can give the patient neoadjuvant chemotherapy, or maybe adjuvant later on if the patient requires so. In a cancer patient, it is always prudent to use your ECOG score instead of Karnofsky performance status. Although these are interchangeable, it is essential in any cancer case. In any cancer case, I repeat again and again that you present your performance status with ECOG, preferably over Karnofsky performance status. Coming to local examination, let us see the video. Coming to clinical examination, it is prudent to ask the patient to sit in a well-lit room on a stool with adequate privacy. We should explain to the patient what we are trying to do with him, and we should obtain a verbal consent before proceeding. It is imperative that we tell the patient we'll be palpating inside the posterior part of the tongue, so the patient might tend to gag, and it is extremely normal. If the patient feels any sort of pain, the examination should be stopped then and there. After we've taken our consent in the presence of a chaperone, especially in a female patient, we go ahead with examination. Look for gross changes in the facial profile of the patient, whether there is a Ryle's tube because the patient cannot feed properly, whether the patient is cachectic, whether the patient is pallor, or any other gross examination findings that might be apparent. Going into local examination, check the oral cavity, especially the lower lip for tobacco stains if the patient is a smoker. Go ahead and check all the subsides of the oral cavity and the adequate mouth opening. The inter-incisor distance can be measured by using 3 fingers or a scale. We look into all the subsides to see the effect of field cancerization, and then we focus on the lesion per se. We tend to examine all of these areas using a tongue depressor. After this, we check the posterior pharynx, asking the patient to say ah and depressing the tongue. Then we focus our attention on the lesion. We look at the normal tongue first, and then we start to palpate the lesion during the palpation. We look for the consistency, whether the margins are tender. It is prudent to take a gauze piece and pull the tongue out and fix it, and then start examining the margins of the ulcer. It is imperative that we check whether the base of the tongue, the floor of the mouth, whether the mandible is involved, and of course the base of the ulcer must be palpated. Here it is actively bleeding and it is covered with slough. After this, we try to palpate for the tumor thickness by using 1 finger. This gives us an adequate depth of invasion, but it must be confirmed with radiology. Bimanual palpation shows us whether the floor of mouth is involved grossly or not. Then we go ahead and focus our attention on nodal stations. We start to palpate from one direction by using 3 fingers over here, and we palpate it against any muscle or bone. We must fix the head with the opposite hand, and we must flex the head to the examining side. Of course, when the head is being flexed, and I start from the level 1A going back to level 1B, then to level 2, level 3, and now we go to level 4. We flex the neck towards the back, and then we relax the sternomastoid level 5 and go back and see the occipital nodes, and of course the pre-auricular and parotid nodes. After that, the examination is completed by looking at the supraclavicular fossa, and of course supplementing this with the clinical examination of the chest and abdomen and other systems as well. So this wraps up clinical examination. Now presenting this to the examiner, already stated about general examination. The general examination is essentially normal. During local examination, the mouth opening is 3 fingers. The orodental hygiene is poor with nicotine staining of the teeth. There are no teeth missing or any sharp or ill-fitting dentures. The tongue protrusion is not restricted. The floor of the mouth appears to be normal, and the rest of the oral substitutes are also normal. And the neck appears to be grossly normal on inspection, but on palpation there is a level 2 lip node. We'll get into that. Now, see, I'm going to explain this local examination finding to you. So, this is the tip of the tongue. This is the tip of the tongue. Now, this is the ulcer per se. Okay, this red thing is the ulcer per se. Now, see, there is a red area over here. This is the induration. This area is the induration. This area is the induration. Always it is important that we describe any lesion from a fixed point. So it is 2 centimeter from the tip of the tongue. Okay, so it is a large 4 by 2 centimeter ulcer that is in the lateral side of the tongue. It is not going into the floor of the mouth. It is not going into the posterior tongue. Now, how will you see posterior tongue? See, this is the tongue's tip. This is the midline, and here the circumvallate papilla are present. So anything which is behind this is the posterior tongue. This is the posterior tongue. And of course, this entire thing is the anterior tongue. This entire thing is the anterior tongue. Okay. Now, if I have to describe this, the lesion is present in the anterior tongue. The lesion is present in the anterior tongue on the right side on the lateral aspect, and it is 2 centimeter from the tip of the tongue. Okay, it is surrounded by a zone of induration. It is surrounded by a zone of induration. See again, this is the zone of induration. This is the zone of induration. See these yellow areas over here, the yellow areas over here. This is slough. This is slough. This is slough. But what about this area? This is the bleeding. This area is actively oozing. Okay, this is active ooze. Okay, now a few things that we need to check here are: number one, whether this is encroaching into the floor of the mouth. So what is the floor of the mouth? We'll discuss this more in your oral cavity. So see, this is the mandible. This is the mandible. This is the alveolus. Okay, this is the retromolar trigone. This is the buccal mucosa. This is the upper alveolus. This is the lower alveolus. So there is a gap in between the mandible, the alveolus, and the tongue base. Okay, this area. So this entire area is the floor of the mouth. This entire area is the floor of the mouth. It's a U-shaped area which goes from this side to the other side. This is called the floor of the mouth. Now, what happens is that if this lesion goes into the floor of the mouth, you will require to reconstruct the floor of the mouth. And of course, if this lesion goes back into the posterior aspect of the tongue, that is the base of the tongue on the posterior tongue, it is considered to be inoperable. Okay, we do not operate tumors which are in the posterior part of the base of the tongue.